I'll let you take it from here.
Well, thanks so much. It's such a pleasure to be here. And I don't think of this as so much as I know it was built that way. What I'd like to do is just make some comments. For those of you who don't know, don't use Zoom, you have a chat button either on the bottom or the top of your screen, depending on which kind of chat you use. Click on that and you'll be able to type in the chat box and see what other people are typing in. Make sure that you type in for everybody, because you can also send private chats. So what I thought I'd do is talk a little bit about some of the main ethical challenges of COVID as we have seen them in my field, split into two major categories, the first of which is in the healthcare system and the second of which is in society as a whole. So I'll start with the healthcare system. What most of us in bioethics were doing for the first few weeks after it became apparent that COVID-19 was going to be a significant pandemic was to begin to write policies for our healthcare systems around what to do if healthcare resources became scarce. So just a little bit of background here. We've been writing these kinds of policies for a long time, especially because of an anticipated flu pandemic, which is really what everybody thought was going to be the first pandemic like this. There are flu pandemic policies in most major healthcare systems. The CDC has a flu pandemic policy. But it turned out coronavirus was a little different than flu in the way in which it spread. It's more contagious than flu, and its symptoms are slightly different, and its spread is slightly different. So the other part of it is that it became clear that if we couldn't, as everyone says, flatten the curve, that is, if we couldn't get the caseload of COVID cases to spread out more over time and not peak or spike all at once, if we couldn't get that to happen, we might be needed healthcare resources. So the first question is, if that were to happen, if we didn't have enough ventilators, how do we decide who in fact gets on the ventilator? Who gets a ventilator when there's competition? So those policies began to be written throughout the country. And it became quite clear quickly that people had different views on this. And in fact, my colleagues and I gathered together COVID policies from around the country, and just last week, an article came out in Annals of Internal Medicine of our comparison of all of these policies. So what do they say? What is the issue there? Well, the issue is this. You have two patients and you have one ventilator. Which patient gets the ventilator? How do you make that decision? So the first and most obvious way that most healthcare professionals would do it was who would get the greater benefit or who has the greater need, which are not the same thing, right? The person who might benefit the most, recover the quickly, and even have the better outcome might not actually be the person who is about to die if they don't get it. So need and benefit are not necessarily the same thing. So some prioritize need, some prioritize benefit. And how do you tell something like benefit? Well, there are clinical measures. For example, one of the most commonly used is called SOFA, S-O-F-A, and it stands for Sequential Organ Failure Assessment. And it looks at 7 measures of how healthy a person is, things like their respiratory function, liver function, kidney function, the coagulation of their blood, respiration, neurological function, things like that. And it comes up with what's called a SOFA score. But then came the question, if my SOFA score is less than yours, does that mean you should get the ventilator and I shouldn't? And how much less is appropriate? How do we, this is a sliding scale score, and it doesn't mean if yours is 1 point higher than mine that you're necessarily going to have a better outcome. So the controversy came about how you even determine clinical measures of who should get it. But it's not only clinical measures, because what happens in a pandemic, in normal medical care, The obligation of your physician and of the healthcare system to you is to do what's in your best interest and to maximize the chance that you individually will benefit and come out of a medical situation as best as possible. And what a pandemic does is it shifts the ethics from individual medical ethics to public health ethics. Public health ethics are different. In public health ethics, we're trying to maximize the outcome for the population. And that may mean making a decision for a particular individual that's not the best one for them, but is the best for the group. And that becomes very tricky, but it's what you have to do, for example, if you don't have enough ventilators. Then even though this person may need one, and that would be in their best interest, we may decide to give it to someone else because that's maximizing the utility of the ventilator. So that became a very important conversation that went on, and people had different views about it. So if we take need and benefit first, what happens when we have two patients who have similar need or could benefit similarly? Well, then there are other controversial second order question is age. Should we give younger people ventilators over older people? And if so, at what stage? I mean, if I'm, 63 and you're 62, is that enough for say, okay, the 62-year-old should get it? Or is that not a meaningful difference? So instead of actual age, they began to talk about life stages. That is, someone who is in a younger life stage than someone else should get priority. So someone who's 25 should get it over someone who's 65 because they haven't gone through young adulthood and middle age, while the older person has had a chance to experience those things. Some policies explicitly say that you should preference the younger person or the person from the younger life stage. Some policies expressly forbid it. Then there's the question of not just stages, but pediatric versus adult. Do we give preferential treatment to children over adults, whatever the adult's age? Well, it turns out that COVID here is also different than flu in that children seem to be less impacted by COVID than adults. So in fact, the possibility that we would run out of ventilators because children needed them is not what's happening. In fact, what's happening is just the opposite, which is that adult hospitals that are running low in ventilators are turning to pediatric hospitals and saying, do you have ventilators that we can use? So the age issue is another example of a controversial issue. And then there's the healthcare preference issue. Should we give ventilators to healthcare workers over other people, everything else being the same? So people of the same clinical status, basically the same age, but we only have one ventilator. Should we give it to someone who is a nurse or a physician or an orderly for that matter, or someone who cleans these rooms, because a lot of them are getting sick. They're putting themselves in very risky situations in order to try to keep our healthcare system working. And there were different reasons why. One is reciprocity. That is, they're putting themselves on the line to benefit us, so they deserve preferential care, and some people have made that argument. The other is replacement value. That is, if we can get this doctor well and treat lots of COVID patients, and therefore getting him well helps more people with COVID than getting someone who works in business well. And then the third is motivation. If I'm a healthcare worker and I know that if I get sick, I'm not going to get any preferential treatment, and yet I'm putting myself with COVID patients every day, I might be less likely to want to work in the healthcare system. So for those reasons, some of these policies do allow preferential treatment, everything else being equal for healthcare workers. Others expressly forbid that as well. And then finally, if everything else is equal, some of them say, well, then you just choose randomly. But the point here is there was a lot of discussion and a lot of differences of opinion around how we should actually allocate these scarce resources in the case of pandemics. Because this is sponsored by the Israeli consulate, I'll tell you another interesting thing about this, which is that in emergency and in a lot of what we think of as utilitarian policies, policies that look at what the best outcome is, if I am on a ventilator and you come in and the ventilator doesn't seem to be helping me that much, and they think that you could benefit more from the ventilator, in many US healthcare systems, not all, they will take me off the ventilator and put you on the ventilator. In Jewish ethics, that is not permitted. Once someone has a life-saving treatment, it is considered contingently theirs. They deserve it until they can no longer use it. So there's an example where two different systems are using two different kinds of values to try to make a very difficult allocation decision. Another aspect of this that has become quite controversial and spoken about is what we think of as bias or hidden bias in those allocation decisions. So for example, if we're going to allocate ventilators first to those people who have a higher, better SOFA score or some other score of how physiologically well they're doing, because we think they'll do better, people who have chronic illness, chronic disabilities, may start out at a disadvantage to getting life-saving treatment. So the disability community has been very vocal, saying, wait a second, this isn't fair. We start out with certain difficulties that shouldn't put us at a disadvantage in getting life-saving treatments just because we have a disability. And so the very basis of some of these policies are discriminatory against people with disabilities. So that's become and second example, I recently saw just a few days ago, someone came out with a map showing access to hospitals in the United States with color-coded, where the color was who's within 15, 30, or more than 30 minutes from a hospital. So there's an access issue. The access issue can be, we don't have a hospital near me, and therefore I have less of a chance to get to the hospital, or there might be a higher barrier before I'm going to go to the hospital. Or I live in a poor area and transportation to the hospital is difficult. And not only that, but here I am sick with COVID, or I think I'm sick with COVID. And the only way for me to get to the hospital is to get on the bus with all the other people on the bus. And here I am thinking that I have COVID. Another issue around that kind of rationing, that is rationing not through a policy or a rational way to think about it, but rather just through circumstances, is what we might think of as pre-allocation rationing. And then what happens there is we are not yet at the point where we don't have enough ventilators. So the policy that controls who gets one has not been put into place yet. And there is a moment when someone, the chief medical officer or someone says, okay, we are now going to put the policy, we're going to start the policy because we've run short of ventilators. Before that, the policy is not in effect. But physicians may be self-allocating, what we call bedside rationing. They may be making decisions about patients, moving them away from ventilators because of decisions they're making that really aren't justified medically. And there's already evidence that some of that has been happening. So in a very quick overview, we could talk about this for the entire hour. There is a lot of activity around and thought around how we think about allocating healthcare resources. All of that was about allocating resources around COVID. But of course, another big issue happening right now is we have allocated resources away from anybody who doesn't have COVID. That is, elective procedures, even procedures that we may not think of as elective. For example, I saw interviewed recently a woman who has breast cancer and wants to get a double mastectomy prophylactically, or has chosen to get that. Is considered an elective surgery by certain systems. So she has to wait until she can get scheduled for her prophylactic mastectomy or for her double mastectomy. So we are rationing not just within the COVID epidemic, but also we're rationing care away from people outside the COVID epidemic. And it's not just medical care, dentistry also. Most dentist offices are closed and are only taking emergency dental care. So people with sort of regular or chronic dental problems are not going to see dentists. The same thing with other kinds of healthcare professionals. So this epidemic has caused us to ration in many different ways. And here's my sort of secret hope. The United States has always rationed. It's just that we pretend that we don't ration. We ration irrationally. We ration through access, we ration through wealth, we ration through insurance status. While every other industrialized countries, including Israel for that matter, ration rationally. They brought people together and they've created decisions on how they are going to allocate care. My hope is that one of the outcomes of COVID will be that the United States will finally begin to ration rationally instead of irrationally, not through whether or not you have insurance, but through policy that decides which kinds of medical care we can afford and which we cannot. So that's the discussion of rationing. If anybody is interested in reading more about it, there's lots of papers, including two that we've written that are coming out these days around that. Another issue that happens in pandemics is a different kind of discrimination that I want to talk about for a minute as we move into the social issues around the pandemic. And there are many issues around discrimination of the pandemic, but history has shown us that as soon as disease, infectious disease, begins to move through a population, people want to blame somebody. We started that almost very early here in the pandemic in the United States with a push by the administration to call this the Chinese flu because of the suggestion that it came here from China, which it looks like now it may not have. And this has been true throughout. So the largest, epidemic in recent history was the flu epidemic of 1918, and it's called the Spanish flu, but it's not the Spanish flu, nor did Spain have anything to do with it. The reason it's called the Spanish flu actually is because it happened during World War I, and the countries that were involved in World War I, many of which had this flu epidemic before Spain, were working under wartime censorship so that their governments would not allow the newspapers to publicize a brewing epidemic. Spain was neutral in World War I, so its newspapers publicized an epidemic that seemed to be brewing in Spain. And because their newspapers wrote about it, since they weren't at war like everyone else, it became known as the Spanish flu, even though it had nothing to, Spain was not the first one to have it or the worst country to have it. They're just the ones that wrote about it. If you look back at history, one of the things you see is that during epidemics, discrimination gets magnified. During the yellow fever epidemic in the early days of the United States, those who had it were then immune, and they had enhanced status. But not only the people who had it had enhanced status. If your slave got the yellow fever and survived, you could sell that slave for 50% more than another slave, because now that slave was immune to yellow fever. So and then we see it with the 1918 Spanish flu as well. We see that there were areas of our country, especially African American areas that were hit much harder because of the social circumstances that they find themselves in. And even today, there are areas where 70 to 80% of the cases are African American, even though the percentage of the population is only 30 or 40%. And there's another way that kind of discrimination happens. We don't know how many healthcare workers in the United States have gotten sick with COVID or died from COVID, because those statistics have not been gathered yet. But they did do a study in the UK about this. And what they found was that the #1 profession in the healthcare world and the #1 number of deaths was nurses. #2 was what they call support healthcare professionals. And that's everybody from orderlies to the people who clean the rooms after people leave them or die, to allied medical professions. And then third were physicians, but at a much lower rate. Well, the interesting thing about that is nurses and orderlies are much more likely than physicians to be from minority groups. So even within the healthcare deaths in the UK, it's oversampled with people from ethnic and racial minorities. So we see here too that in these kinds of situations, we have an oversampling of sickness and death in pandemics of people who are poor and people who are from disenfranchised populations. Moving a little bit more, and then I'm going to finish up and we can talk about some of this. Moving a little bit more to the social, and by the way, just one last thing about blame. Yeah, we blamed Spain for the Spanish flu, and we tried to blame China for this. But Jews, of course, have historically often been blamed for these kinds of pandemics, and that did not, we did not escape this time either. There have been writings both domestically and internationally blaming Jews for a variety of different kinds of causes for this pandemic. So another area that has become extremely controversial is social monitoring. So if we really want to try to stop a pandemic from spreading, where it is spread through social contact, through touch and through aerosol expression, either through breathing or sneezing. Well, one of the things you want to do is keep, as people say, I call it physical distancing, not social distancing, to keep physical distancing or contact distancing. There are two interesting tech developments, one very much involving Israel, that have been promoted for this. The first is monitoring. And in fact, the Israeli government asked Shin Bet, the intelligence agency, if they could use their technologies and their lists to monitor Israeli citizens and to keep track of those with COVID. Well, the Israeli Association of Public Health objected so strongly to that it was shut down. But this idea, which China is doing with cameras, not only is China putting cameras outside the doors of people who have been identified as COVID positive, they are just going to their houses and mounting a camera pointed at their front door to make sure they don't leave the house, or that if they do, it is in a way that's been officially sanctioned. But in some cases, they've actually mounted the cameras inside of people's homes to monitor their comings and goings. So that's happening in China. China is the most surveilled country in the world. 8 of the top 10 cities in the world in number of cameras per capita are in China. And just interestingly, the other 2 in the top 10 are London, England, and you're not going to believe this, Atlanta, Georgia. We are the 8th most surveilled city in the world. Anyway, so this idea of is it okay for a government to monitor the activities of its citizens is an interest, and you can monitor in 2 ways. One, the way China is doing it, that is, monitor people to make sure that they don't violate sanctions against mingling. But the second way you can do it is through contact tracing. So one of the things that's always happened in pandemics, if I came into a hospital with the flu in 1918, I would be interviewed by a public health official, and he would say, tell me every person that you have come in contact with in the last week. And I would sit there and try to remember. But never, because our cell phones track us all the time. And if me with my cell phone come near you with your cell phone, there are actually ways, if we let that data be used by governments, that they can say, aha, Paul Wolpe came in contact sometime in the last week with Sierra Weiss, and so Sierra because Paul has COVID. And should we allow governments to do that? Should we allow them that kind of access, and should we allow them to monitor us that way? There too, there is controversy. Some countries have allowed it, some countries have not allowed it. Public health surveillance has always been in tension with privacy, even back in the Spanish flu, and it certainly is today. So this kind of digital tracing that we're talking about is being used in Singapore, it's being used in South Korea, it's being used in China, and the question is, should we allow it to be used here? One other thing about that before I get to the second type of digital surveillance that we might find a lot more acceptable is this. In the yellow fever epidemic, if you had the fever, if you had the disease and you got through it and now you were immune, you could get an official card from state governments that you could carry around saying, this person has had yellow fever and so is immune. So now that's what they're doing in China. They are giving people QR codes that are color-coded so that you can tell this person has had COVID and is now past COVID. Now, the problem is, one, we don't actually know the degree of immunity that COVID bestows on you. We don't know if you had COVID, if that means that now you're immune to COVID, and how long that will last. We just don't know because the virus is too new. But they're doing that in China. If it turns out that having COVID means that I am now immune to getting it again, do we want somehow to give people some indication that I'm okay to interact with? What will that do in terms of creating kind of a two-tiered society? It's exactly what happened in yellow fever, where people who had it ended up being able to move more freely, got better jobs, could do more commerce than those. So that's another issue that we have to think about. The second kind is a more voluntary thing where you can download apps, and these are very common in South Korea, and in fact, Israel is one of the pioneers of this. And so the app does not send any information to the government. It doesn't even send any information to Apple and Google have gotten together to create one of these, and none of the information will go to them. Instead, what will happen is I voluntarily put the app on my phone, and then I voluntarily put in my COVID status. That is, at COVID, or I think I have COVID, I can put that in. Now, when I interact with somebody, and I go and I have a conversation with Sierra's phone tells her, you have been in contact with someone who seems to have COVID or who may have COVID, you should get checked. So that kind of application is now very common in certain countries. In South Korea, Israel has been encouraging its population to download their particular version of this. called homogen, a shield. The name of it is shield. There are controversies about whether or not that's a good thing or not, and there are problems with it. I mean, after all, it's done through Bluetooth. Bluetooth is quirky. Not only that, if you live in a dense apartment house, you know, Bluetooth can go through the walls. So your downstairs neighbor now gets a warning that they've been near someone with COVID because you live upstairs from them, even though they've never seen you. So there are problems with these technologies, both ethical and practical. And then social isolation itself has ethical issues. So I will end with this because people time for questions and things, and I could obviously talk about all of this for an hour easily. And that is not only the ethical challenges of putting people in isolation, but, you know, Governor Kemp recently, Governor of Georgia recently, he was going to reopen certain businesses, and those businesses were high contact businesses, massage, tattoo, things like that. There's an ethical question about who and how and when we should begin to move back into the workplace and back into social life. It is generally agreed upon by most people in ethics that Governor Kemp's decision was much too premature. But as I like to point out, so when won't it be? This is not a pandemic where there's going to be a moment, an on-off switch, as Fauci said, where all of a sudden everyone says, okay, the epidemic is over and we can all go back to work. There's going to be a judgment made no matter when we decide to do it. And that judgment will be a harm-benefit judgment. To the degree that the epidemic still exists, is going back to work and the benefits of going back to work, or the benefits of restoring social life greater than the harms of the remaining risk. And there is no way to figure that out empirically. It's a judgment call. There will be differences of opinion. It will differentially affect different kinds of people. Right now, today, even essential workers. If I'm a physician and I can get into my car and drive into the physician's parking lot and just go into my job, I have much less risk than the person who has to get on the bus, onto the crowded bus, and then switch to another bus in order to get to the same hospital that I'm working in. So there are differences even within the same kind of function that will differentially impact things like returning to work and returning to social life. And the final thing to say is, studies have shown, this isn't opinion, studies have shown that cities, for example, with better leadership, there's been a lot of these of the 1918 flu epidemic. And so, for example, in that epidemic, Milwaukee was famous for having really strong and well-designed city leadership, and their cases of flu were significantly less than similar cities. So leadership becomes important in pandemic. And I think having the kind of deficit in international leadership, I mean, who is the international spokesman and leader right now in our world? There isn't someone who has emerged, even though there are people like the prime ministers of Australia and New Zealand who've done fabulous jobs, and their countries' prevalence and their countries' social activities have been much better than in a lot of Western countries, or South Korea. So the first case of COVID, for example, in the United States was January 20th. The first case of COVID in South Korea was January 20th. So the first identified case in both countries was the same day. South Korea at the end of March had done 400,000 COVID tests. The United States had done 40,000. South Korea has 80 million people. We have 328 million people. So they had tested a much higher population. They knew where COVID was breaking out, and they could target their activity, on the United States, we had the entire country shelter in place. And because of that, South Korea never had to shut down the entire country. They had a lower death rate per capita, and they're already opened back up. While in our country, we shut down the other country, have the highest number of deaths now in the world, and still are not open. So leadership in these kinds of situations is extremely important. I will end there and give us some time to answer questions and have some conversation.
Thank you so much, Dr. Wolpe, for sharing your insights. I see we have a couple questions in the chat, so I'll read one and let you answer and then move on to the next.
Right.
So the first question is, in an emergency and lack of resource situation, where is the ethical line between supply and demand, economy, and profiteering?
Great question, thank you. There is a gray area, clearly, but there are also clear violations. In countries with centralized health services, and one of the things I think that this COVID epidemic has certainly emphasized is the importance of universal health care here in the United States as well as everywhere else. In a system that's centralized, that kind of profiteering is much harder. In a privatized, fragmented system, like much easier. There were some cases in the COVID epidemic that people heard about. There was a guy who went out and bought a whole bunch of sanitizers and things and hoarded them, was selling them at high prices. And the social pressure on him became so great that he just and put them out. It's an ironic thing, isn't it? So if I anticipate that demand for something is really going to go up because of sort of a general economic downturn, I'm celebrated for being prescient. But if it happens during an epidemic, I'm condemned for being mercenary. And so we think of these things differently based on the desperation of people in needing those kinds of resources. So yes, the profiteering has been disturbing, but we need to be vigilant about it and we need to stop it. We should also point out, of course, so has the generosity. Restaurants, pharmaceutical companies, supply companies have given away millions of dollars worth of goods, food, and supplies over the course of this. The charitable giving has increased significantly. So I think we need to have a bit of a nod to both the good and the evil in people's inclinations.
Great, thank you. The next question is, what is your recommendation for universities as they contemplate a return to in-person classes in the fall? What type of public health surveillance should universities deploy?
Right. So universities are just one example of institutions that have a really tough set of decisions to make about how they're going to operate. One of the interesting things, of course, about this pandemic is it has taught everybody that it's much easier, that working in place is actually much more efficient than they thought it was. And teaching classes online and doing scholarship online has replaced doing it in person at universities. And I'm not sure that universities will ever go back to the way it was fully beforehand. On the other hand, everyone understands and agrees that there are advantages to in-person learning and to encounter, the learning encounter that cannot be duplicated online. There are 50 people on this call right now. If we were in a classroom, the feeling of this, the interaction around this, the engagement of the other 40 or so of you who are the audience would be completely different. And the attention would be greater because it's much easier to, go and do something else or to lose your attention or to check your email when you're in a virtual situation than when you're sitting in a classroom. So this is going to be a challenge. Emory has not decided yet whether it will have classes fall, nor have most universities. Some have said they're not going to decide until July, which is really, that's really shocking in some ways. If you're an incoming freshman and you still don't know, July 15th, whether you're moving across the country to Atlanta to start at Emory, that's a burden on you and your family, especially if you just find out, at the end of July that you're not going to be moving across the country. So these are really tough decisions. Universities are taking them very, very seriously. I can tell you this isn't being done flippantly by anybody. There are real competing interests here. There are economic interests. There are educational interests. There are research interests. There are people who have had to put thousands and thousands to death. There was not just mice, but other experimental animals too, because there was no one to feed them and no one to take care of them. There were significant research projects that had to be stopped. There are medicines that will not be developed or will not be developed as soon. There's knowledge that we will not gather as quickly because of this epidemic. So it's a very, very tough decision, and I don't think there are a couple of universities that said they will start already. They've already committed themselves to starting and are putting in place all kinds of distancing, smaller classes, chair between every student, those kinds of things. They're already trying to do that. Again, it's a judgment call about how much risk you think is worth taking for that benefit.
Great. We have 3 more questions that I'll ask, and then we can wrap it up. So the next question is, doesn't a paradigm in which people who have been infected are free to move about put us at risk for people intentionally infecting themselves? What kinds of ethical deliberations can be made here, and how might we navigate such a potential reality?
So it's always a calculation. It's always a risk-benefit calculation. To what degree? So one of the things people have to understand is that there are risks and there are illnesses and there is death that is caused by social distancing, right? It isn't that everybody's really healthy because they're staying at home. No, people are dying because of social isolation as well. So, and people are dying because of the economy slowing down and because of their loss of jobs. People are dying because they can't get caretakers to take care of them and they're infirm. So it isn't, all of the negative isn't on the side of COVID mixing. It's also on the side of isolation. How you calculate that is really difficult to know. But there is a middle ground between full physical distancing and full social and work mingling. And that is what our society is, and every other society right now is trying to negotiate. How do we begin to engage each other in a way that keeps people generally healthy and mitigates some of the downsides of this? I think that was most people's objection, by the way, on the right and the left, so it isn't a partisan thing, of Kemp's decision to open, of all things, massage parlors, tattoo parlors, hairdressers. These are high-touch businesses where mingling, where the chance of transmitting COVID is higher. That may not be the first place you want to start in reopening the economy. Why not start with big box stores or some place where you can actually maintain distance and where you're still helping? He said that one of the reasons was these are people who have are poor and on the lower end of the pay scale, so they're struggling. But so are all the people who run the cash registers at Target and Walmart and all of those places. So we have to do it in a way that recognizes where the risks are and tries to mitigate them. And there is no right answer here. There's going to be experiments throughout the country. Some states will go faster, some states will go slower. Some restaurants opened, some restaurants didn't open when Governor Kemp allowed them to open. So there's going to be experiments on the large scale, experiments on the small scale. And if we get a COVID in the fall, as many epidemiologists are predicting that we will. By the way, another sobering thing to know is when the Spanish flu, which killed 50 to 100 million people worldwide, 50 to 100 million people worldwide, there was a spike in that when it first came out that then extinguished. And then it came back a few months later with a vengeance, and that's when the majority of people who were killed were killed. So we could see that same pattern here, with this being the first wave of COVID and then having a much more significant wave in the fall. Well, if that were to happen, then everything's going to shut down again. So, you know, it really, there are people whose nature is to be more cautious. There are people whose nature it is to be more aggressive around returning to work. And what I really think is not productive is to condemn the other side and portray this in a partisan way. I mean, this is something we all have to get through, and we all have to negotiate together. I think it's right to say that you think somebody has done something or has made a policy that's ill-advised or wrong, and to fight against it, that's fine. But there is no perfect answer here. It's a really difficult challenge.
This next question is sort of a follow-up to the answer you've just given. What advice, precautions, or ethical advice do you give hands-on healthcare providers like chiropractors, massage therapists, and PTs as they start to reopen?
Right, so what we need, you know, the first level of thing we need, the second level of thing we need, of course, is a vaccine. So it is a failure of leadership on the national scale, it's failure of leadership locally throughout the country that we didn't do what South Korea did and start aggressively testing and creating as many tests as we could way back in February when South Korea started. We were very late to that game, which means that we don't have as good tracing of our citizens in terms of their COVID status as South Korea, for example, does. But we'll need to get better at that, and we will need to use precautions. If I were, you know, in one of those professions, I would certainly be taking people's temperature before I allowed them to, you know, get a haircut or a massage or whatever it is. We should have people tested as soon as those kinds of tests are available. Masks and gloves are absolutely mandatory. So those are the kinds of things that I think we'll need to use in those kinds of professions. They're not going to be perfect, and every person who is part of that profession is going to have to decide how much risk they're willing to assume.
So the last question we have for this lecture is, besides the possibility of the pandemic resulting in a more equitable healthcare system once we get through this, what are some of your other predictions for healthcare delivery, et cetera, in the US post-COVID?
Well, it's going to change. It's already changed. I think, first of all, on the healthcare side, they're going to to issues of preparedness. And this, there's going to be more worldwide collaboration about these things. I don't think we're going to be caught as unawares in the next epidemic, at least if it's not 100 years from now, like Spanish flu was. I think that governments are going to be more sensitive to this. You know, people have been, this was not news, and this was not surprising to anybody in public health, anybody in epidemiology. I mean, this has been predicted for decades that this was going to happen. Nobody knew exactly when, but everybody knew it would. And not only that, 2018, 60,000 Americans died of the flu. We just passed the 60,000 mark with COVID this week. Now, in 2017, 2018, when 60,000 people died of the flu, we had an effective vaccine. Only 37% of Americans took it. I don't think that's going to happen again. I think people are going to be a lot more willing to take their flu shots and other shots that we get that will prevent these kinds of infectious diseases from spreading. I think our system is going to be better prepared for the next one. I think people are going to take the flu more seriously. I think this was a wake-up call, and it's a shame that it had to shut down the economy, cost 60,000 lives so far, and probably more over the next few months, and hopefully not a great deal more over the next year. But I do think that at least people recognize that what public health officials and epidemiologists have been saying for years was not, alarmist, that these kinds of things really can have this level of impact.
Great. Thank you so much for sharing your insights on the behalf of the Consulate General of Israel in Atlanta. We really appreciate your time and being with us today. Thank you for everyone joining us here today. This will be recorded and available online for you to share with your family and friends who were not able to make it today. So thank you for joining us, and stay tuned for future lecture opportunities. Thank you, Dr. Wolpe.
Sure, my pleasure. Bye, everyone.